Good evening. Welcome to SpectraCell's Thursday night webinar program. Tonight we bring you stress, an overview of its overwhelming physiological effects presented by Dr. Ron Grabowski. Resource materials along with slides are available in the resource box on the left of your screen. Please be sure to submit any questions in the Q&A box and we will do our best to address them at the end of the presentation. At this time, I would like to welcome Dr. Ron Grabowski.
Thanks, Jessica, and good evening, everybody. As Jessica mentioned, we're going to talk about stress tonight, and this is a very interesting topic, and I think you'll be surprised on how stress really affects us. But what's also interesting is how our nutritional status may allow us to handle stress, or whether or not stress is actually causing some nutritional deficiencies. The thing that I think is very important about this is all of us at one time or another in our practice has told our patients, well, you need to find some way of decreasing your stress. Go read a book or go on vacation or something like that. But how many of us really have thought about telling our patients, well, we need to test you for certain nutritional deficiencies because your ability to really handle that stress may be related to your nutritional status. Stress has been around a long time. As you can see, Hans Selye, an endocrinologist back in 1936, talked about this particular topic. He mentioned about, once again, how do we respond and how do we adapt to this particular stress. And what I want to emphasize, just like Selye did, is stress can be both a physical or a psychological etiology. And that's really important because a lot of you probably treat people that exercise on a regular basis, or whether it's just for leisure or for health reasons. And some of you treat, of course, athletes that are very intense, whether it's high school athletes or college athletes or professional athletes. And we're going to talk about that. How does physical stress affect us? And when we talk about going and relaxing and possibly trying to decrease stress by exercising, you can see we may overdo our exercise, which may get us into trouble just like psychological stress. So it's very important to keep in mind throughout this evening that stress is both psychological and physical in etiology. You can see here from the American Institute of Stress that there's 50 common signs and symptoms of stress. And you can see there's numerous things here that you have dealt with your patients. Patients more or less give you this on the initial examination and you're trying to address those. What I've done, and you'll see this throughout the lecture tonight, is I've taken these and put them into various categories and showing you how these particular categories are related to what your specialty. If you're a dermatologist, if you're a gastroenterologist, if you're a dietitian that specializes in several of those areas or one of those areas, you'll see how stress really comes into play. But also that there is a lot of research out there done by these researchers that have shown how this may affect us. And once again, I'm going to go through that. So we're going to show you some categories. And of course, you're all familiar with these signs and symptoms in these various categories, but I'm going to relate the nutritional information tonight to each of these categories. For example, this morning, I saw a young girl. She's got migraine headaches. And of course, she's a very good student. She's a high achiever. And the things that I'm going to talk about today are going to show you how they're related and how we can treat these people that are high achievers, that have migraine headaches or tension headaches. And it's not just go and relax, take a break from your study. It's what is happening to these young individuals or adults that, from a nutritional standpoint, that are continuously driving these diseases or these signs and symptoms. Gastroenterology, of course, we always hear this from our patients, or a lot of times we hear this from our patients that, oh yeah, my IBS is always worse when I'm under stress. Or if a big project's coming up at work and I'm stressed out about it, my Crohn's disease gets worse, or my ulcerative colitis, or I get a burning sensation in my stomach area. Of course, maybe developing a so-called stress ulcer. So the point is, there are physiological and biochemical things that are occurring or deficiencies that these people may have that's not allowing them to function normally. Think about this. if I put 10 of you in a room together and we all put a certain stress on all 10 of the subjects, do you think all of us would handle that stressful situation the same? No. Why not? Why don't we handle a stressful situation the same from one person to the other 9 people involved in that particular room? Because we all are different biochemically. And once again, this has a big role in how we function on a daily basis. Of course, when we talk about stress, one of the things that usually comes up is people that have stress often have depression or anxiety, or they can't sleep at night, or once again, they can't focus, or they get so-called brain fog. And then, of course, we give those individuals antidepressants or anti-anxiety medications or some other type of medication that's going to help some of their signs or symptoms. And once again, I'm going to show you how nutritional deficiencies come into play with, once again, these sections. Cardiovascular. How many of you have listened to a patient walk in and say, yep, I just did my general physical with another doctor. I'm coming to see you because my cholesterol is really high or my triglycerides is really high or my blood pressure went up, and I've never had high blood pressure. I've never had cholesterol problems or triglyceride problems. And if you weren't really taking a good history from them, you might say, oh, it's hereditary. Your mom has cholesterol issues or your dad has hypertension, so it's hereditary. Is it really hereditary, or is it that there's certain nutritional problems or deficiencies that are occurring that are leading us down that path? And once again, this is something I think you'll be very surprised about today, and see how there's some mechanisms that set this up and how certain nutrients affect these mechanisms. When we talk about stress, of course, we have to think about some stress hormones. Of course, with the HPA axis and the sympathetic nervous system, we talk about, of course, norepinephrine, epinephrine, and cortisol, which we know are stress hormones. Of course, we also know that renin, angiotensin, and aldosterone comes into play. And I'm going to show you how these particular products are affecting our health and how nutrition affects these products. And that's what's so interesting about this. As I mentioned earlier, there's some wonderful research done by these individuals out there that have connected this, but some of this research isn't reaching the journals that most of us read, that you have to look into the chemistry or the physiology journals or, once again, the endocrine journals. You know, they might not be in the Journal of American Medical Association or Lancet or something like that where most of us clinicians look, but there's definitely evidence out there connecting this. So once again, this was published in a cardiovascular journal and talking about the angiotensin and how it goes into, of course, the mechanism of angiotensin 1 and 2, and, of course, eventually going into aldosterone and, of course, causing sodium and water retention, of course, high blood pressure. Or we look at endothelial damage from, once again, the other branch of this particular mechanism. But the point is that these particular physiological steps are well known. I mean, you've seen these in your education. You read these in pharmaceutical literature where they're talking about these mechanisms where medication is affecting one of these steps. You know, one of the things we hear about a lot today is ACE inhibitors, and how ACE inhibitors affect this particular step, and that's how, once again, it may modulate or control or manage, whatever term you want to use, the person's ability to have a normal blood pressure. Here we talk about cholesterol and aldosterone. I'll show you some connections there, and you can see how cholesterol starts. It goes through these different hormones. Eventually, aldosterone is made. Another branch of this particular mechanism goes over to, once again, cortisol production. And so we're talking about cortisol as being a stress hormone. We talk about aldosterone as far as being a major player in high blood pressure. And so how do these come into play from a nutritional standpoint? How do we really manipulate these, or how do these particular hormones affect us in a way that it may manipulate our nutritional status? So it's really the question is it the chicken or the egg? Is it the nutritional deficiency first that doesn't allow us to handle stress, or is it the stress that causes nutritional deficiency that which sets off the signs and symptoms? And I really don't know that answer exactly because, once again, you'll see it's maybe both ways, that a person might have enough of one particular nutrient, and when they get under a stressful situation, a particular stress hormone causes a physiological effect, and then other nutrients are used to try to alter that effect. On the other hand, the person may be low in a nutrient, and it doesn't allow these mechanisms to be handled properly. As I mentioned, I've seen it, you've seen it, where people take a stressful job, they've never had cholesterol problems, and all of a sudden now they have high cholesterol. Is it really hereditary, or is it something happened biochemically with them to drive the body now to make increased amounts of cholesterol? So let's talk about aldosterone, since I showed you some mechanisms there and some pathways, physiological pathways, and how they're related. But look at this. This was published way back in 1963 in British Medical Journal, showing that aldosterone definitely has an effect on magnesium status. Well, why is this interesting? Why is this important to us? Because, once again, if we have this elevated aldosterone and it increases the excretion of magnesium, then, of course, it's going to lead to magnesium deficiency. Well, magnesium deficiency, as you will see throughout today, can cause high blood pressure, can cause elevated triglycerides, can cause elevated cholesterol levels, can cause glucose elevations or insulin resistance. So when a person has an abnormal aldosterone status, this is what can happen. And so, once again, you can see how this particular product is going to affect magnesium. And on the other hand, I'm going to show you how a deficiency of another nutrient may actually cause an elevated aldosterone level. So, what about magnesium? Okay, we know this. You probably have had this. I've talked to clinicians in the past when I lectured to individuals, and even to my patients. I say, have you ever experienced where you've sat somewhere and your eyes started twitching, your cheeks started twitching? Well, those are classic signs of magnesium deficiency. And when I talk to my patients about things like that, I say, well, when does that occur? Well, it always occurs when I'm under stress. Well, isn't that interesting that your eye or your cheek starts twitching when you're under stress? Well, what is stress doing to us? Well, we know that stress causes increased loss of magnesium in the urinary route. So over time, this is something that occurs. When people are stressed, what often happens is they talk about being tired. Well, after a stressful week, I'm always exhausted. When weekends come, I don't even feel like doing anything because I've had a stressful week, and so I just sit around the house. Well, why is that? Why don't you have any energy on the weekends after a stressful week? Well, as we all know, magnesium helps make ATP. And so if we don't have adequate ATP, we're going to be exhausted. And once again, what do they do when people get exhausted? They usually consume things like caffeine to give them energy. Well, once again, we know that caffeine is a diuretic and causing further loss of magnesium. So here we showed that the average person, or a large significant amount of individuals, do not consume enough magnesium in their diet to begin with, and now things are happening to them that are causing further loss of magnesium. And when are they going to catch up? When are they going to fill that tank of magnesium back up in their body so it can have normal function? And once again, that's something you have to think about. And how do we check to see if, once again, magnesium is adequate? And we'll talk about that later today. So here's some dermatological situations where you can see people get frequent blushing, excess sweating, they maybe experience cold or sweaty hands and feet. I treat a lot of hyperhidrosis in my office, and we're going to talk about that. We're going to talk about a nutrient that actually affects that or has a high tendency to affect that. And why is that occurring? It's not hereditary. If it is, then show me some gene or some mutation where that's causing that. Why all of a sudden, like I said, at 20 or 30 or 40 years of age, or maybe at 11 years of age, a person starts to experience that? If they don't experience it until their 50s or 60s, if it's hereditary, why didn't that occur in their teens or their 20s or 30s? Why all of a sudden in their 50s did it occur? So once again, think about this when you are reviewing this information and talking to your patients. Genital urinary signs and symptoms. Once again, we've heard this a lot where people say, well, when I'm really stressed, my libido decreases. Well, is that just a coincidence that happens? When other people are under stress, does their libido decrease? Or do they have more frequent urination? I mean, what's going on? Once again, we're talking about the sympathetic nervous system. We're talking about the HPA axis, and we'll talk more about that. How do those particular pathways get affected and cause these signs and symptoms, and what, from a nutritional standpoint, is going on? Then, of course, we talk about the social signs and symptoms. Person goes to work, or they start missing work, or they start getting sick more often when they're under stress. Have you ever thought about that? And think about yourself or patients when they come in and say, well, I've been sick 10 times this past year. Well, what's new about last year compared to previous years? Oh, I took this new job on, or my schedule is more stressful. I'm traveling more. So do we just say, oh, well, everybody has stress in their life, you just have to live with it? No, I don't believe you do. I really believe that there's things from a nutritional intervention that can decrease the severity of how stress affects us and how we handle stress. And once again, it's not just my belief, it's what the literature is actually stating. So let's talk about this whole situation when people talk about they get stressed out, they start to have GI problems. It could be irritable bowel syndrome. It could be a stress ulcer. It could be something even more serious than that. And then all of a sudden they start to have fogginess in the brain. They start to have depression, anxiety. There's a lot of research out there today showing that there's a strong connection between what they call the brain-gut axis. So we know that the autonomic nervous system, this whole connection with, once again, the brain-gut axis is something that is well-versed. We don't maybe know everything about it right now, but there is quite a bit of information out there and certain pathways that we have to consider. One of the things that is often coming up in the literature, as you know, is inflammation and how inflammation affects every system in the body. And you can see here that the effect of stress on the inflammatory bowel disease and how it might mediate this whole hypothalamic pituitary adrenal axis, and this is when people talk about the brain-gut axis. And when that happens, we find that people get a condition that's intestinal permeability, or some people call leaky gut syndrome. We know that the microbiome may change when people are under stress. We know, of course, that inflammatory cytokines occur. And how can we handle those or modulate those so we don't get these serious side effects of a bleeding ulcer or severe migraine headaches or some other conditions, some other systems that we talked about, or how can we make sure that that person is able to sleep better when they're under stress? And they say, well, I've been under a tremendous amount of stress and I can't sleep. I used to be able to sleep 8 hours with no problem. Now I can't sleep more than 2 hours without keep waking up. Something happened chemically for that to occur. So as you know, irritable bowel syndrome is a chronic condition, and you can see that it almost affects 12% of the global population. And you think about that in numbers, it's a huge amount of individuals. And we hear about medications being used. We see some people put on antidepressants or anti-anxiety. We have other people that are put on anti-inflammatories. We have people put on muscle relaxants. I mean, there are numerous ways of treating this condition from a pharmaceutical means. But are we really addressing the root of the problem? What are we doing to normalize or adapt to our stressful situation, as Hans Selye said at the very beginning of this lecture? I think it's very important that we think about that. And like I said, there's some strong evidence. So when people are under psychological stress, and we talk about the GI tract, you can see the different things that occur. And this is what's so interesting about this topic, is how it affects every system in our body, and how these signs and symptoms that we hear about every day in our practice from our patients, we address them, and we know they're there, but we just say, oh yeah, if you have stress, you're going to have intestinal permeability, or you're going to have maybe increase in bowel habits as far as diarrhea, or you might have less bowel habits, meaning you're constipated. How is that affecting? Like I said, we know that various anatomical and physiological changes occur, and how does nutrition come into play? So you can see these are some of the treatments that are considered or looked at today from a pharmaceutical standpoint. And the point is, what are they doing, or why are they giving antidepressants for a GI condition? Because they're trying to manipulate certain factors, whether it's serotonin, whether it's norepinephrine, whether it may be the cortisol, whatever the products are, they're trying to manipulate some product in the body. And that's where the nutrition comes into play, is if we are addressing the same product, it could be cortisol, it could be serotonin, it could be dopamine, it could be whatever of these products that these pharmaceuticals are trying to address, we're doing it from a nutritional standpoint. And once again, like I said, there's some very nice science behind this. So when people are under stress, one of the things, of course, that happens is people get headaches, right? They get tight muscles, they get headaches. So when they get headaches, they take a product like Tylenol, or they take an NSAID, and as a result, what does that do? That further exacerbates, of course, intestinal permeability. There is numerous articles out there showing how NSAIDs definitely increase intestinal permeability. And we now know, because of that intestinal permeability, how is that then connected to the brain-gut axis? We know that there's a strong correlation there. We see it in things like ADD, we see it in depression, we see it in anxiety. So here's a person going through a physiological situation. They're under stress. It could be physical stress, like I mentioned, or psychological stress. Like I said, we know that athletes, anywhere from 30 to 90% of people that exercise on a regular basis as an intense level have GI complaints. So let's take the average, 30 to 90%, so let's say it's 50%. So 1 out of 2 people that exercise at a pretty intense level, I'm not just saying walking, for 5 minutes. I'm talking about maybe exercising 3 or 4 more times a week, an hour each time. It could be weightlifting along with aerobic type or cardiovascular. Here they're doing that to so-called decrease their stress level, but they may actually be affecting their GI tract when they're doing it. We know that's true definitely in marathoners, triathletes, CrossFit people. Those people have a much higher incidence of GI conditions than people that just do real leisure type of activities. So then they get those conditions. They're trying to do that for stress relief, and they're actually damaging their GI tract. Then they might injure themselves, and then they, of course, take an NSAID, which causes further intestinal permeability, and once again causes some neurological issues. So there's been a lot of studies, as I mentioned, human studies as well as animal studies, and I'll talk about some animal studies, and we, of course, take those studies and kind of propose those into the human type of arena. But at the same time, there are some human studies confirming animal studies. But one of the nutrients we know that is affected with stress, whether it's surgery, whether it's a trauma, whether it's, like I said, psychological stress or exercise, is glutamine. And yes, glutamine can be a neuroexcitatory product or a precursor, but at the same time, glutamine is very important for GI tract integrity. So when we are under stress, we know that glutamine levels may drop. And if they drop, we know that muscle integrity may be affected, and we definitely know that intestinal integrity may be affected. So maybe through that psychological stress, we're dropping glutamine levels, and now people start to have GI problems. Irritable bowel syndrome, ulcerative colitis, gastric ulcers, whatever. And so as a result, these people start taking maybe some medication. They take a PPI for their gastritis, or they might take something else for their lower GI tract. And maybe, once again, you introduce them to a probiotic, which is beneficial. But if they have a glutamine deficiency, and that glutamine is very important for maintenance, you can give them a probiotic and you're not going to correct the glutamine. So, I've said this several times in some of the webinars, and some of you that might have heard me lecture in person, if your car needs gas, don't give it oil. You need to give the body what it needs. And the question is, how do you know what it needs if you don't objectively test your patients? Here's a connection, of course, showing you the HPA axis and how we know that cortisol levels go up. We know when cortisol levels go up, we have insulin resistance. Have you ever thought about this? And maybe you have put yourself in this situation, or you see patients, they come and say, since I've been under stress, I'm craving carbohydrates. I just can't handle it. I mean, every time I walk into a room or at my office, I'm working 10 hours a day at my computer, and I have some sweets there, or I'm drinking soft drink, or I'm eating candy, or I'm eating other carbohydrates. Why is that? Why is that when a lot of people are under stress, they start to consume a lot of carbohydrates? Well, think about it. One of the things that's happening is we are changing our insulin and insulin receptor capability or efficacy or maintenance. And you can see here, look at these pro-inflammatory cytokines that are released through this process as well. And I'm going to show you how some of these things are altered when we handle our nutrition. Here's some information about the hippocampus. We know the hippocampus is very important in this whole more or less mechanism. And look what it says here. The hippocampus is very vulnerable to zinc deficiency. And zinc has a huge impact on neuropsychological symptoms. Okay? Serotonin. We cannot make serotonin without zinc. We cannot make dopamine without zinc. Zinc actually works as an anti-inflammatory. It actually affects interleukin-6, one of the inflammatory products that I talked about earlier. Okay. You can see how the hippocampus is a major target for glucocorticoids. We know that glucocorticoids, of course, can affect, it can be an anti-inflammatory effect, but it can also affect our glucose tolerance. And so, once again, it's a built-in mechanism that's very important. But if it overworks or has this accelerated effect, it's going to go too far one way. That's going to cause some other signs and symptoms to develop. And then once again, we have to try to compensate or modulate that particular response. It's just like histamine. Histamine, people talk about, histamine is a negative thing, but histamine is a good thing. I mean, histamine is very important to us in small or regulated dosages. So, when we damage tissue, histamine gets released. It's very important for vasodilation. But if we leave histamine in the system for too long, it's going to be detrimental to us. And that's the same thing with some of these other products I'm talking about. We need aldosterone. We need cortisol. We need these products, but we need them modulated, not to overcompensate for some of our mechanisms, or if they get into excess, how are they going to be problems. So I talked about the chicken or the egg. Which came first, the chicken or the egg? Was it the stress that caused these deficiencies, or was it these deficiencies that were present that didn't allow you to handle stress? So look at this here. It says zinc deficiency elevates the HPA axis. So once again, if you have a zinc deficiency to begin with, you're going to have an abnormal HPA axis activity, which then may increase glucocorticoid secretions, which then may get the ball rolling. So that's the part about the chicken. Maybe that is the problem first, is these people that don't handle stress well have a deficiency that hasn't been determined yet, okay, because someone hasn't done diagnostics on them. They get in a stressful situation. This mechanism here gets accentuated, and as a result, it causes other things to occur. And then you talk about this continuous increase in corticosterone, and that causes problems even more. So, and what's interesting about this is zinc actually is one of the nutrients that helps with glucose regulation. And glucocorticoids are one of the problems of glucose control. So you can see how it's very important, those glucocorticoids, but keeping them in balance. We talk about metabolic syndrome, okay, all the time. Oh, yes, you have metabolic syndrome, you have this abdominal obesity, you have this insulin resistance, you have this cholesterol and triglyceride elevation, you have high blood pressure. Look at this statement on the very bottom. In the U.S., over 40% of people over 60 suffer with this metabolic syndrome. So do we just accept that and say, well, yeah, when you hit 60, 40% of you are going to have this? Or is something happening physiologically, biochemically, that's setting this off? What are people doing or not doing in their daily activities or dietary means to maintain certain biochemical balance so these things don't once again occur? Look at metabolic syndrome and magnesium. We know that. We know that magnesium has a huge impact on blood pressure. It has an impact on lipids, whether it's triglycerides or cholesterol, and it has a role in glucose regulation. So I'm going to go back here for a second. Look at what this is saying. We're talking about glucose, we're talking about, once again, cholesterol and triglycerides, and we're talking about hypertension. Magnesium has a role in all three of those. And then if you don't have good insulin function, if you have insulin resistance, there's a good chance, once again, you're going to gain weight and you become obese. How many times have we heard that? Oh, I took this stressful job on and I've gained 30 pounds in the last 3 months since I've had this stressful job. Yes, well, why did you gain 30 pounds? Did you really change your eating habits? No, in fact, I don't eat very much because I'm working so much, I'm so stressed out that I don't have time to eat. So it might not be excess calories. So what's happening from a micronutrient standpoint that may be causing the high blood pressure, the cholesterol, the triglycerides, or the elevated HbA1c that the person responds to? So look at this. Magnesium deficiency contributes to the aspects of metabolic syndrome. So we know that this is one nutrient that is involved. Once again, think about it. Person's stressed. We know in human and animal studies, when people are stressed out or animals are stressed out, they urinate out more magnesium. Magnesium is responsible for making ATP. They become fatigued. Now they start to consume more caffeine products to keep them going, and it's a diuretic which pushes the magnesium loss even faster. And even though this is a citation in 2006, I can show you citations back in the 70s and 80s that show that diuretics have an impact on magnesium, whether it's prescription diuretics like hydrochlorothiazide or something like caffeine. So what about magnesium deficiency and inflammation? We talked about inflammation markers going up when people are stressed out. Why does that happen? Why does it happen in one person and the other person it doesn't happen? You look at an individual that may be more into vegetables and other products that are high in magnesium, and you don't see an elevated CRP. You see a person that doesn't consume a lot of the so-called magnesium-containing foods, and their CRPs go up. How many of you have diagnosed someone with an elevated CRP, and all of a sudden you say, oh, you need to be on fish oil? Well, they might benefit from fish oil or omega-3s because it's an anti-inflammatory and it can reduce the CRP. But what happens if the underlying cause of that elevated CRP is actually magnesium and you're given omega-3s? Are you correcting the problem or are you covering up the problem? Are you masking the actual cause by giving the omega-3, but you're getting an end result? So you're getting a benefit by lowering CRP because you're showing that you're decreasing inflammation in the body, but are you really getting to the root of the problem? And I think that's really important to think about this evening and in the future. Are you really addressing the root of the problem, or are you masking some other situation? The renin and angiotensin and aldosterone, once again, this system, okay? Once again, look at this. There's growing evidence to show that activation of this system is one cause of insulin resistance. And they feel it's causing, one of the mechanisms may be increase in oxidative stress. So we talked about, of course, physical stress. We talked about psychological stress. And, of course, we all have heard the term oxidative stress. Of course, we need to decrease these free radicals. We need to quench those free radicals with antioxidants. And there's numerous antioxidants. And once again, did you pick or did you select the right antioxidant for your patient? Here's a mechanism. Here's a great schematic, and this is out of Annals of Internal Medicine in 2009, so just in the last decade. And you can see there's some beautiful work done by these researchers showing some mechanisms of how aldosterone and insulin resistance occurs. And once again, it goes through each of these particular mechanisms. It shows how it affects the liver, shows how it affects skeletal muscle, once again, the adipose tissue, and so on. So I think it's very interesting. So if we can take a nutrient, a micronutrient, like zinc or magnesium, that may help modulate aldosterone, it may be, once again, one of the mechanisms, not the only, but one of the mechanisms that helps with insulin resistance. So we talk about, of course, the NMDA activation and how this affects calcium and how magnesium helps kind of modulate this and how stress, once again, affects this particular mechanism. And you can see glutamate is talked about, and we know that glutamine can go to glutamate, but it doesn't always have to do that. Once again, it is a precursor to glutamate, and that's neuroexcitatory. But you can see here that magnesium deficiency in rats induces this elevated pain, hyperalgesia, due to these receptors. So when people talk about chronic pain, and people talk about, it started out in my back, and now it's going to my legs, and it's going to my arms, and I have this general pain, and sometimes people will go to clinicians, and they say, oh, you have this general pain, you have fibromyalgia. As you all know, or hopefully you all know, that according to the rheumatology literature, it shows that 18 points need to be evaluated to truly diagnose someone with fibromyalgia. And once again, it's not just, I have this general muscle pain. Those people should be getting diagnosed with fibromyalgia. That's not the proper way of diagnosing fibromyalgia. There's certain criteria that have to be, once again, looked at or found to say, yes, this person truly has fibromyalgia. A general muscle pain is not fibromyalgia. And yet you can see how magnesium deficiency in animals have shown this, but we also see this in humans, that magnesium has a big role with modulating pain. So what about visceral fat? You can see here how stress-induced HPA axis actually may have activation and have a role in this body fat accumulation, and this excess body fat accumulation causes inflammatory cytokines to be released, and then this causes a full pathological mechanism. And so a person has insulin resistance, they start gaining weight. As they start to gain visceral fat, they now have inflammation. As they have inflammation, it comes back and feeds this other mechanism, and it's this vicious circle. So we have to break that circle. And once again, I've shown you a couple of them. I've showed you a little information about zinc and magnesium that play a role. And then we talk about, of course, coronary artery disease. People talk about, inflammation due to lipid peroxidation. We have this whole thing about foam cells being produced, and then, of course, as we have inflammation, we have calcification of that area, and, of course, we have blockage and further problems. Well, look at this. It shows you that, once again, we have this inflammatory cytokines, but magnesium may actually suppress the inflammatory response with the endothelial cells. And once again, I've given you just a few sightings to confirm this. And as I told you earlier, magnesium is one of the major nutrients that gets affected under stress. It has over 300 enzymatic-related functions in the body. And seriously, if there's only one nutrient that I could carry in my office to give my patients, it would be magnesium, and because of its function. Now, this picture, this slide, is to show you something. I always say this to my patients and to clinicians out there. Think about people that have been under stressful situations and watch what happens to their hair. And you can see here in former President Obama, where his pre-president years, he had this dark hair, And then during presidency, you see his hair turn gray. You say, well, yeah, when people are under stress, their hair turns gray. Well, why does their hair turn gray? Why do some people that are under a lot of stress, their hair doesn't turn gray as fast as other people? Is it hereditary? I mean, we always like to use that term, everything's hereditary. A lot of things are hereditary. These people have this because it's hereditary. Is it really, or is it a nutrient deficiency that's causing it? Well, look at this. Pantothenic acid, B5, has these nicknames. If you go back to the history of B5, you will see these terms. Anti-gray hair factor, anti-stress factor, water regulator, of course, hyperhidrosis, pantothenate, there's different forms, of course, pantothenate, calcium pantothenate as far as the supplemental form. But the point is, as you saw from this previous slides, one of the things that can happen to people when they're under stress is they start to get sweaty palms. They start to get sweaty feet. Their entire body may perspire more intensely than another person. Why does that occur? Something's happening with those individuals to make that occur. So here's some physiological functions and responsibilities of B5. And one of the things I want to point out is here under metabolic is you see a component of acetyl-CoA. And if you go back and think about your biochemistry years, acetyl-CoA is essential for our fats, our proteins, and our carbohydrate pathways to go into the Krebs cycle. And if that doesn't occur, we're not going to produce enough ATP to have energy. And so the point is that when people are under stress, we may utilize this up more rapidly, whether it's physical stress or psychological stress. And if it becomes depleted, people have other things happen. Their hair turns gray. They can't relax. They are maybe more anxious and various other things that are strongly related. Well, one of the hot topics today is methylation. People are always talking about methylation, or a lot of people are, as far as, have you had your MTHFR checked? Are there other things in the methylation pathway that need to be checked? Look at this. They've actually shown back in 1982 that there may be a methylation relationship with stress/anxiety. And so what have we done about it? And when we look at a person that's a so-called poor methylator, do we even say, well, you're a poor methylator, you're probably not going to handle stress as well unless we correct that methylation pathway. And what's one of the things that people often talk about? When you're stressed out, take your B complex, right? B complex seems to help some people or a lot of people with stress. Why is that? Well, we know a lot of the Bs, B2, B6, B12, folate, are in the methylation pathway. And then you look in the second bullet here and you see that choline is a major player. And choline's in the methylation pathway. So once again, how do you know whether someone is deficient in one of those unless you have some objective way of testing them? You just start throwing supplementation at people and hope you hit the right one? I don't think any of us want to practice that way. We want some objective way of determining it. You can see here, B12 deficiency has been documented for years that it can cause impaired memory, irritability, depression, dementia, psychosis. We know it's associated with migraine headaches. It's huge. I mean, B12 is one of the most common findings I see in my migraine headache sufferers. And once again, how many people are being treated for migraines with B12? The question is, how many of you test for B12, and what's the best test? So you can see here that psychiatric diseases have been shown for years to affect our blood status. We might see a macrocytic or megaloblastic anemia, and of course they say, well, take B12. Well, do they just take cyanocobalamin? Do they need to take methylcobalamin? Do they need to take adenosylcobalamin? Have you done an MTHFR on them? Do they have any mutations? I think, the whole nutrigenomics and epigenomics and all that stuff is becoming very popular today, and there's a reason why. And there's a lot more to learn in the future, I think, about the whole nutrition connection with disease. But there's a lot that has also been done in the last 2 or 3, 4 decades that we have overlooked because it maybe hasn't been published in the journals that most of us clinicians read. But once again, and that's why I like to cite a lot of these statements, and I want to show you that it's not just in the 2006, 2014, that we have known some of this in the 1970s and 80s and 90s. Look at this. In a large study of patients known to have B12 deficiency, they showed elevated methylmalonic acid, which, as you know, is a functional test. Homocysteine is a functional test, okay? And the reason why this was done, they wanted to see how these correlated with your hematocrit, your hemoglobin, and so on. So some of the standard tests that all of us have been trained on, the CBC, the CMP, the urinalysis, we're finding out now really aren't as sensitive as we thought they were. Look at some of these neurotransmitters that are correlated with B6. So when we talked about serotonin and dopamine and norepinephrine and histamine and GABA, you know, all these, none of them can be produced without B6. So what is a person doing that may be affecting a B6 test? One of the things may be your patient may be following a gluten-free diet. Gluten-free diets have a tendency to force someone into B6 deficiency. So here a person gets on a gluten-free diet, they're doing pretty well the first 6 months, maybe a year, and all of a sudden a year and a half, 2 years later, they don't handle stress well, they can't concentrate, they're depressed, they're anxious. So did you ever think that that previous year or 2 years of gluten-free diets might have caused a B6 deficiency and actually is needed to help their depression and their anxiety? And there's studies. There's some small studies and there's some larger studies that actually show that. Look at the choline and anxiety. I mean, there's several benefits of choline. We know that choline has sometimes helped muscle cramps or spasms. It helps with liver integrity as far as helping maybe prevent fatty liver. And now you can see that it may be related, once again, with depression and anxiety. The fatty acid composition, we always talk about this, you know, of take omega-3s if you're anxious or if you're depressed. How does that work? Well, we talk about neuroplasticity as one of the components. But you can see how they affect the receptor function, the neurotransmitter uptake, the transmission of the neurotransmitters. And so, once again, a nutritional deficiency that's not allowing normal physiologic functions to occur because, in this case, maybe membrane integrity. We talk about, of course, the polyunsaturated fats versus saturated fats and balance of all that. And once again, one of the things that is very well documented out there is the benefit of DHA and how that particular omega-3 has a big impact on inflammation, coronary status, neurological status. We see it in possibilities of even skin disorders. I mean, there's a lot of importance of these particular fatty acids. And the point is, what are you doing to make sure that a person has adequate amount? Are you just saying, oh, yeah, you're taking 1,000 milligrams of DHA, that should do it? Or do you want more of an objective way of measuring it? Here you can see they talk about the uptake of serotonin, increase in serotonin transport. Okay, as I mentioned about inflammation and atherosclerosis and omega-3s. So there's, once again, back in the 90s we knew this, and even before then. But the point is, one of my professors once said to me, and I think it's so applicable because sometimes people might say, well, Ron, why are you showing 1970 literature? Or why are you showing, 1980 citations? We're in 2016 or 17. One of my professors once said, Ron, old literature doesn't mean it's not good research. Just because it's been done 30 years ago does not mean it isn't still good research. And if you look at a lot of people that do research, they build their present research projects on old literature. So they had a basis for doing something. So just because something was done 20, 30, 40 years ago doesn't mean it's still not good research. And I think that's something we have to keep in mind. So, of course, we talked about the, omega-3s and omega-6 and how, one is more inflammatory and one's more anti-inflammatory effects, and the ratio we're looking at, and that I think is well known by all of you out there, and it's very important. And of course, you look at here, the DHA and depressive disorders, and they show that the DHA status definitely has a mechanism, and this was published in the American Journal of Clinical Nutrition in January 2009, showing the anti-inflammatory effect and the membrane fluidity and structure effects, and how it may affect, once again, the cytokines, the neurotransmitters like serotonin, norepinephrine, dopamine. This is why some people benefit from that, and that's why when they say, well, how does omega-3s work? I mean, how do they help with depression? How do they help with anxiety? You can see there's been research out there on why it works. It's just not by coincidence. There's a physiological or histological reason why this is occurring. So I'm going to show you a few case studies to kind of pull some of this together, and I apologize for the concise or limited amount of information because of the time frame, but there's a lot of information out there and more information on how stress affects us nutritionally and how a poor nutritional status, once again, allows us to handle stress. But here's actually some cases that shows you how they can correlate. If you look at this, it's a 50-year-old female. She has a high-stress job. She suffers with depression and anxiety, and so she was, of course, prescribed Zoloft and Xanax. But go back to what I said about some of the things that can modulate the nervous system. We talk about methylation. So if you look at this lady, we did this SpectraCell micronutrient test, and we look at B2, we look at folate, okay? We look at B6, we look at B12, we look at choline, we look at serine. All of those are in the methylation pathway. Then we talked about how stress affects our glucose regulation and how we can see people that are stressed have elevated glucose, so they start to have elevated HbA1c. And then you look, here she has insulin resistance. Zinc modulates it. We talked about how zinc and aldosterone are related to one another. We talked about zinc and dopamine and norepinephrine, and we talked about it in serotonin's relationship. So once again, when these medications are prescribed, they're trying to affect some of those receptors, like we talk about SSRIs, selective serotonin reuptake inhibitors. We're trying to manipulate serotonin. Well, folate has a role with serotonin. Zinc has a role with serotonin. B6 has a role with serotonin. Serine has a role with serotonin. So this may be the root of the problem that's causing them to need a medication like that. But are these medications resolving the problem, or are they just resolving the symptoms? And that's, I think, very important, because all of us want to really get to the root of the problem when we look at the patient. Here, once again, is showing you that this is what it presents like, okay? So you can see the red squares are functionally deficient. The black squares represent borderline. But look at the person's B levels. Now, what we want these squares to be, which represent the patient, is high into the white as possible, or at least in the white. The white means that they have adequate amount and adequate function of that nutrient. And once again, why is it been said in the past, if you are stressed out, take a B complex, because that stress B complements your condition and may help with it. Well, this is a good example. Look what's happened to her Bs. So look what happens to her insulin capability as far as she is displaying insulin resistance. One of the things that's causing it is a chromium deficiency. So did the chromium deficiency initiate this, or did some hormonal or other physiological change or inability to modulate the systems cause this to occur? Once again, is it the chicken or the egg? And I think that's very important. So I want to end with this, because one of the things we always try to do is when people are stressed out, go home, try to relax, meditate, do some of these other things that will decrease stress. And I think one of the things that's very important is once you replace negative thoughts with positive ones, that you usually have positive results. So yes, it's very important to think positively and to go that route, but I've showed you a little bit of information regarding how specific nutrients like B5, zinc, magnesium, omega-3s can have an impact on some of these physiological changes, whether it's glucose elevation, blood pressure elevation, cholesterol elevation, how they really come into play. And I think that's so important. So the point is that this is very, very important when we look at this, that you are looking at a situation where people need to have a positive outlook, but can they have a positive outlook if they are not at an adequate biochemical status? I think it's something to really think about in a different way of evaluating our patients. So one of the questions is, can you explain how a gluten-free diet can cause choline deficiency? I don't think I said choline deficiency. I was talking about B6 and also selenium. Choline, once again, is somewhat dependent upon estrogen. And this is one of the reasons why men have a higher tendency for choline deficiencies, or postmenopausal women have a higher tendency for choline deficiencies. We try to achieve our choline status by food consumption. Okay, and of course, egg yolks are high, or one of the higher sources of choline. So this whole thing several years ago, when people said don't eat eggs because, once again, you can elevate your cholesterol because eggs are high in cholesterol. Of course, there's a lot of information showing that that's not the case. And once again, choline is very beneficial for normal liver function, and that's where a lot of our cholesterol, of course, can be modulated, is through the liver. So that's the thing to look at. So there's several things that can occur with dietary limitations, but the ones that often are talked about are, once again, with the gluten, is your B6 and selenium deficiencies. Another question was, to get adequate DHA, do we recommend just taking DHA by itself or a combination? Once again, there is a situation where people talk about certain ratios that we don't want too much EPA because it may affect the DHA activity. Most of our omega-3 products out there seem to be higher in EPA versus DHA, so people do talk about ratios that maybe we should have maximum of a 3-to-1 ratio of EPA to DHA. If you look at a cardiovascular standpoint, in regards to acute myocardial infarction, or we look at depression and things like that, and stroke, that DHA seems to be more important in that aspect than the EPA. Once again, the process is measuring it. Do we just give people DHA or EPA or both, or how do we measure it? And once again, SpectraCell has that capability. They have a testing procedure called the Omega Check, and they look at the DHA, they look at the EPA, they look at the DPA, and they give you a Omega Check to see if that person has adequate amounts. Don't just assume that they're getting adequate amounts because they're eating a lot of fish or they're taking a supplement, because everything, once again, is different. B6 is found in, animal products, and someone mentioned that, and that's true, okay? So I'm not saying you can't achieve B6 by being on a gluten-free diet, but the point is that does occur. I mean, B6 deficiency does occur with gluten-free diets, and once again, selenium deficiency also occurs. Yes, and there's different ways of achieving B6, but the point is that I was just giving an example that every diet, I don't care what diet you're on, has gaps. And we need to know about those gaps, or we need to know about a way of measuring for those nutritional deficiencies. It's just like, when people talk about being vegan, everybody jumps on B12. Okay, if you're vegan, you're B12 deficient. Well, how many of you realize that if you're vegan, you also have a high tendency for zinc deficiency? You also have a high tendency for carnitine deficiency. You have a high tendency for CoQ10 deficiency. But everybody seems to just jump on B12. And the thing is, for zinc, people say, well, yeah, but zinc is found in nuts and seeds, and you can get from nuts and seeds. But you also realize that the bioavailability of zinc from nuts and seeds is much lower than the bioavailability of zinc from animal protein, like, say, beef. So even though it's contained in those foods, what's the bioavailability and what's the patient's capability of pulling that micronutrient out of that food? So that's the other thing. Just because, and I used to say this to my students when I taught at the college level, just because you eat healthy doesn't mean you are healthy. It increases your chance of being healthy, but it doesn't guarantee it. And so you need to have some way of objectively determining that. Last question, is there a relationship between magnesium and tensile tremors? Yes, there is. In fact, like I said, magnesium has a huge impact on several systems. And the nervous system, the neuromuscular, the skeletal system, the endocrine system. I mean, there's so many different relationships with magnesium. But let me just say this about, since we're talking about magnesium. And this is where nutrient-nutrient interactions come in. You can give someone a large dose of magnesium on a daily basis and actually cause a B1 deficiency, or you can cause a calcium deficiency, or you can affect other nutrients that are divalent cations, like zinc and copper and manganese, various things like that. So the point is that our body wants homeostasis. And how do we achieve that homeostasis if we don't have the right balance or the right ratios? And of course, we don't know all the perfect ratios yet, and we don't know, the perfect balance for every person. I mean, everybody doesn't have the same balance. But the point is that we have certain requirements in the body by every one of us on an individual basis. And how do we know they're being achieved? By just symptoms. And as I mentioned, a common laboratory finding, an elevated CRP. An elevated CRP can be decreased by several nutrients. Vitamin D. We know that it can be decreased with CoQ10. We know it can be decreased with magnesium. We know it can be decreased with omega-3s. So when you see a patient that has an elevated CRP and you say, yes, you have inflammation, how do you know the actual cause or the root of that inflammation if you don't do some objective tests? And that's one of the major points I want to emphasize tonight, is we see some beautiful work done by these researchers that have found some mechanisms that may be causing elevated blood pressure, cholesterol, triglycerides, or, migraines or depression or whatever. And there's not just one answer to high blood pressure. There's not just one answer to depression. But yet, we seem to pigeonhole our patients sometimes into that. Oh, you have depression, you need magnesium. Next clinician says, oh, you have depression, you might need B6, or you need B12, or you need folate. How are you coming up with that by just because a person has depression? Once again, there's biochemical, physiological relationships that have to be achieved to put that person in a balance, in homeostasis. And all of us are different. And that's the big point I hopefully get across tonight, is there's mechanisms we know in physiology classes that we've had, but there's nutritional intervention that affects those mechanisms. And things that we do or we don't do in our lifestyle affect those. And that's why none of us handle stress the same. And hopefully this has opened up your view a little bit on how nutritional intervention may have a big role, and I mean a big role, in stress and how people respond, and the relationships of common findings of blood pressure and cholesterol and blood glucose elevations are related. So I appreciate your attention, and hopefully this has stimulated your thought a little bit on considering nutritional intervention when people are in stressful situations.
Thank you, Dr. Grabowski. We are currently out of time for any more questions. Have a wonderful evening.